Now I'd like to introduce our speakers from the Parietal Lobe Brain Health Center. First, we have Dr. Alejandra Sanchez Lopez. Dr. Sanchez Lopez specializes in the science and care related to aging and its effect on medical treatment. She is also the Associate Medical Director at Parietal Lobe Brain Health Center. Next, we have licensed clinical social worker Howard Hahn. He specializes in helping older adults with cognitive impairment and supports their families through resource navigation.
Good afternoon, everybody. I'm very happy to be here with Howard and talk about what we do every day and what is our passion. We call it this lecture about what I wish I knew about cognitive impairment and dementia and Alzheimer's disease. And I think we're going to talk about many questions that we get in sort of a daily basis when we see our patients, and we hope that is informative. And we also welcome your questions. We are here to share everything that we can with you. And just a little bit about me. My background is first I did internal medicine, and then I'm a geriatrician, and I fellowship training in behavioral neurology. And we're gonna get started. So our outline is first we're gonna talk a little bit about like the brain functions, just a brief overview, in order to understand like the concepts of dementia, mild cognitive impairment, what's cognitive aging, what causes cognitive changes in aging, can it be prevented? And I think we got a question about that. So we're gonna be able to talk a little bit about this. And then what is the evaluation process and what treatments, what is the treatment if there are cognitive changes or cognitive impairment? The mentioned stages, some of the behavioral disturbances that occur in dementia, and how we can help patients and their families, or what can you do if you do have a loved one with dementia, and some recommendations when caring for, again, with someone with dementia. So in order to function in the world and be able to do any of the activities that we do on a normal day, we make use of different cognitive and behavioral skills. And when we lose or have difficulties with any of these capabilities, things that are common to us may become difficult to complete or to do, or even impossible. Things that are, for example, cooking or driving, or even social engagement, talking to somebody, being able to, have a conversation and understand what's happening, just having empathy for somebody else. All of that is, there are functions of the brain. And then here we have, a figure. It's kind of a simplistic figure of the brain, but I think it does a good job. And then we see, and I don't know if you can see my cursor, but we see here there are different colors. What we see in color pink and red is the frontal lobe, and the frontal lobe has functions of executive function, basically the ability that we have to plan a task, and organize our thoughts, and do something that may require multiple steps, and also controls the behavior and personality. There are other parts of the brain, but that's just in general. And movement. Then here in the back, we have the parietal lobe, which is green, and then a little bit of orange. And the parietal lobe helps us to sort of make sense of our visual world and perception. It also helps us with arithmetic and sensation. And then we have yellow, the temporal lobe, and then this lobe is in charge of memory functions and comprehension and language in general. Usually, like the left side for most people, which are right-handed, is in the left side. But in general, it's like language and memory. And then in the back, we have here the occipital lobe, that this is mostly for visual processing. And this is the cortex of the brain. This just is in general, but then the mental processes, we call them like cognitive domains. These are higher order mental processes. And we have memory, executive function, attention, language, and visuospatial. And on the right, we have some examples of what could change in all of these cognitive domains. So in memory, the most typical probably like when we hear of a complaint is that somebody has a short-term memory loss. Basically, they have difficulty remembering things that happened recently, like minutes or hours, or maybe days earlier. And it can be conversations, or they can be events, or where they put something and they cannot find it. So that's a memory example. Difficulty learning new information, or becoming repetitive because you don't remember what you asked. And in terms of executive function, as I mentioned, this domain helps us organize our thoughts and our activities and plan ahead. And things that are more complex, perhaps like finances or even cooking, can be affected because of this. And people can become disorganized, not sure what to do with some of the paperwork, or having problem solving if something happened, and judgment. Then we have attention, and here it can present as becoming distractible or lacking focus, or having changes in the attention throughout the day. Then we have language, and that's another common complaint. We hear people that come here and they say that they have word finding difficulties. And we're going to talk a little bit more about that, what could be normal and what could be abnormal. But then, these word finding difficulties may be because you just cannot think of the word immediately, but it comes right after, or maybe you lose the meaning of a word or how to pronounce the word. So it can be also a speech problem. Language can also implicate changes in comprehension, both verbally and written language, and even grammar. So it can be many things within this cognitive domain. And then we have visuospatial difficulties, where you can have difficulty recognizing people or places, or discriminating different parts, or when you're driving, you may have difficulty driving because of visuospatial difficulties. And as we see, that there are many cognitive changes that could happen, and it's just not just a short-term memory. Then other functions of the brain that are very important to consider are behavior and mood. So sometimes when we find changes in this area, it can be related to some illness of the brain. So for example, not everybody, of course, but sometimes we find that late onset mood disorders, when somebody never had any history of anxiety or depression, and just late in their life they develop this could be a sign. It doesn't mean that there's a neurodegenerative process or other process in the brain, but something that might alert us. Changes in personality, for example, somebody could become like they used to be very caring, and now they don't have sort of this sense of the other and the empathy that they used to have, or the things that they used to like, it just changed completely. So changes in personality in late life can cause or can be caused by an illness of the brain. Motor and sensory changes, the most common one, like Parkinsonism, and not just because of Parkinson's disease, but the other reasons. And then, or frequent falls. Again, there could be other causes for that, but also something that alerts us that there might be something happening in the brain. And lastly, sleep. So changes in sleep pattern. Now, this is complicated because we do expect some changes in our sleep as we age. Typically, as we age, we might go to bed earlier and wake up earlier. But then when there's something that is much more pervasive of changing the sleep and wake cycle dramatically, that can be a sign of some sort of brain illness, or moving when we are asleep, more purposeful movement, like we call it dream enactment behavior. So these are just some examples. So are any of these changes normal for age? Now, some changes, and I would say the minority of changes, are something that we call cognitive aging. So I'm going to explain a little bit more about what's cognitive aging. So cognitive aging is really a process of some cognitive changes that occur as we age, and it's an ongoing process. And it's very variable because each person can be different, and not everybody has the same symptoms. But what is true is that they have to be occasional and non-disruptive, right? Something that happens, once in a while, and then it's just really not impacting at all your day to day. And a good example is that when you compare, or like when somebody, compares themselves to somebody their similar age, and maybe they're experiencing something similar, that could be a sign that it's cognitive aging. But oftentimes, people are not aware of their own symptoms, and that can also be the awareness of the symptoms can be a sign of some brain illness. So really, what you need to do to know if this is cognitive aging, we recommend that you have a proper evaluation, that you have talk to your primary care doctor and figure it out. And then what's common? So some of the most common symptoms might be that some slower processing speed, like the ability to go to understand something might just take you a little bit longer, but you get it, or some difficulties in the learning process. That it costs you a little bit more time, but when you were young, but still, you're able to learn information. The divided attention is something very common, or also called multitasking, the ability to do different things sort of at the same time, or do one thing and sort of going back and forth. That can be impacted, and then oftentimes also word retrieval difficulties. So you probably have experience from time to time that you cannot come up with a name or like a specific word, but it just comes back after. So those are some common symptoms, but they have to be occasional and non-disruptive. What is not normal aging, which would be consistent with cognitive impairment, for example, short-term memory loss, difficulty performing things that they used to be able to do, and you cannot do, they cannot do cooking, do some cooking or driving, difficulty in familiar tasks, and problems with language or word finding, feeling disoriented in just like the time or the place, having poor judgment, or executive function difficulties, and misplacing items like very often, very frequently, or having changes in like paranoia, for example, or personality. That's changes in personality are never something normal. And something that is very common too, loss of initiative or motivation, what we call apathy. And I think Howard will talk a little bit more about that. So what do we call these abnormal symptoms, right? And what causes them? So we are in the category of mild cognitive impairment or dementia, which is also called major cognitive impairment or major neurocognitive impairment. Dementia is the same thing, but mild cognitive impairment is when we have when there are symptoms like the person or somebody they trust, they notice some of these changes, and they did some testing and sort of it's abnormal as well, but they do not affect their functional independence. So that's mild cognitive impairment. When there are cognitive symptoms and then they're consistent with also some of the testing, like we can see that there's objective evidence, and they affect the independence with daily function, that's dementia. And what could dementia look like? So for example, somebody that maybe they have memory difficulties and they cannot really keep track of the medications they take. So now somebody else has to help them just staying on track of the medication, more than just reminders, right? Here and there. It's just like somebody else had to take over because they cannot do it themselves. So that's sort of the difference, between mild cognitive impairment and dementia, is the loss of independence in one or multiple activities of daily living. So it could be medication management, driving, cooking, taking care of finances, any of those. Now, mild cognitive impairment does not tell us if it's going to progress to dementia. Some people that have mild cognitive impairment may stay there, some may progress to dementia, and then maybe sometimes could improve if there was something that was causing some cognitive impairment that we can talk about it. And there are a differentiation in the types of mild cognitive impairment. I'm just going to call it MCI, which can be amnestic or non-amnestic. So the amnestic type, which is the one that affects mostly memory, that's that tends to progress to an amnestic type of dementia. Not necessary, but I don't know. Are we? I'm getting a message here. Are you still able to hear me?
Yes.
Okay, great.
I can
Sorry.
hear you.
Okay, wonderful. Thank you. So the amnestic mild cognitive impairment has a higher risk of developing an amnestic type of dementia, which is typically Alzheimer's. It's a higher risk. It doesn't mean that it will progress, right? So for us to know if somebody with mild cognitive impairment will progress or not, we have to get more information. And typically, it requires follow-up over time to see if things, how things change. And then neither of these terms tell us what's the cause of the dementia or the mild cognitive impairment. And neither of them are normal for age. So, and if sometimes I still hear it, right? Like, dementia is normal for somebody who, I don't know, who's 80 or just say a number. So it's not normal. It's common, but it's not a normal part of aging. And, even like in the world, there was a report on I think it was a 2019 Alzheimer's report that said about 60% of health providers may think that dementia is part of normal aging around the world, right? And so there's still this thought that may be normal, but we know it's not. Now, in terms of the causes of dementia and mild cognitive impairment, we start by thinking what is the syndrome that best fits this presentation, meaning that what is the conglomeration of symptoms and signs. So is it more amnestic, or there is some other presentation like a behavioral variant from the temporal dementia, which may cause more behavioral changes, personality changes? Or is it more related to movement? And I'm just going to talk a little bit about like some of the possibilities. And we have here different types of neurodegenerative diseases. Like we have here Alzheimer's disease, we have frontotemporal dementia, some of the atypical Parkinsonism. And then we have non-neurodegenerative, we have like a vascular cognitive impairment. And here we have either it can be microvascular disease, which is like the small vessels of the brain may be sort of damaged, and then they at the same time causes damage in the brain, or somebody that had a stroke and then that caused cognitive impairment. And about 30% of people that have a stroke may develop dementia in the last year. So it's also very common. The most common cause of dementia and mild cognitive impairment by far is Alzheimer's disease, which is about 60 to 80%. Now, we know the classical type, which is the amnestic type, which is more short-term memory loss, but there are other types of Alzheimer's disease. It could affect more the frontal aspect of the brain, which causes more of a behavioral dysexecutive presentation, or it can affect more the posterior part of the brain, the parietal, and cause more spatial difficulties, or it can have a language presentation. These last two are typically more early onset dementia, or early onset Alzheimer's disease, I should say. And the difference between early onset and late onset is just the age. So anybody that presents before age 65 with a diagnosis of dementia is called early onset. And then after 65 is late onset. And then we have the frontotemporal dementias. And this is actually one of the most common causes in early onset dementia. And then here we have the behavioral variant, in where the frontal and the temporal aspect of the brain are affected, and then can cause changes in the personality, the ability to have empathy, the drive to do things. They can also have disinhibition in the social aspect, right? That's also part of the brain. When we know what the social norm tell us to do in a situation, which is really in the frontal lobe. So if there starts to be some disinhibition, it could be related to one of these diseases. Then we also have PPA, meaning it's a primary progressive aphasia. So some of these can present with language difficulties. Could be more motor and not really related to a stroke. It's just like this part of the brain is causing changes in the speech. And then semantic primary progressive aphasia, where there are changes in the semantic memory, which is really like the information that we gather over years about people or objects, how they relate to each other. It's sort of like our dictionary, like semantic memory. And semantic PPA, people start to lose the meaning of things and words. And then we have the atypical Parkinsonisms. Most common one would be a Parkinson's disease dementia and dementia of Lewy bodies. And really the difference between these two is just in Parkinson's disease dementia, there is motor changes like Parkinsonism, and then people develop dementia. And in Lewy bodies, they typically develop first some of the cognitive changes and other changes like visual hallucinations, or they have actually dream enactment behavior or attentional fluctuations, and may develop some motor changes of Parkinsonism. And then we have other types of atypical Parkinsonisms. They're a little bit less common. They're here. And then we have other types that are much less common, but I'm going to mention here the traumatic encephalopathy syndrome. It's something that we learn more from people that were boxers or NFL players. For example, we have learned that repetitive traumatic blows to the brain can cause changes in cognitive impairment. Other include also prion disease. This is also rare, but it can cause a rapidly progressive dementia. HIV over many years can also cause a neurocognitive disorder. And then we have other types here that are like much less common. And then these diseases of the brain obviously have the different stages, right? So we know actually that somebody that develops Alzheimer's disease, it took 20 years for the proteins of Alzheimer's disease to deposit in the brain in order to cause a change in the brain and then cause cognitive impairment. Now, we have a preclinical disease, which means like where there's no symptoms, but there are changes in the brain, and then sometimes people develop a sense of change in their cognitive abilities, but maybe they don't like the testing doesn't show anything. And then we talked about mild cognitive impairment, and then we have mild, moderate, and dementia, which I'll talk a little bit more about that. So as you see, dementia is different from Alzheimer's disease, which is the next slide. So really, dementia is an umbrella term. There are many types of dementias. And Alzheimer's disease could be a type of dementia, or could be in a mild cognitive impairment stage. And like I said, it's about 60 to 80% the cause that Alzheimer's that causes dementia in 60 to 80% of cases. And we know it's like the third leading cause of death actually in California, which is it's very interesting. Now, in regards to dementia, there is every 3 seconds in the world somebody develops dementia or is diagnosed with dementia, which is really an astonishing number, right? So it's very common for sure, and we have to find ways to prevent it, which I'll talk about it next. And to the right, we just have a figure of how the brain could look like, healthy brain versus an advanced case of Alzheimer's disease. So we see that there's a shrinkage or volume loss of the brain as compared to the healthy brain. In this case, it's typically in the messiotemporal lobes. Now, it is very common that as we age, we start to accumulate some of these pathologies in the brain. And actually, there are studies that in people that are older, and typically in the oldest old, 80, 90, that may or may not have dementia, and they have these pathologies in their brain. So what is the difference between somebody who develops cognitive impairment from somebody who doesn't? So now we are talking about cognitive reserve. So each person may be different. So somebody may just need a little bit of brain atrophy to develop the symptoms, and somebody else may need a lot of atrophy or shrinkage of the brain to develop symptoms. And people might not have just one thing. They could have, a mixed pathologies, which is actually very typical to see Alzheimer's disease, and also mixed with vascular. That's common. Now, another question is, what's the difference between dementia and delirium? The two of them are related in a way, but they are different. So as I mentioned before, dementia, it is a change it's a cognitive impairment that is happens over time. It's gradual, and versus delirium, somebody can just suddenly develop in a day, in hours, sudden change of their cognitive function. And dementia is, like I said, progressive and permanent, but delirium can be fluctuating. So maybe in the morning they're fine, but then later in the afternoon, they seem a little bit confused, but then they're fine. So it can be fluctuating. And dementia, we know that there's some sort of pathology affecting the brain, either some deposition of proteins or vascular changes, something that we know that is happening in the brain. In delirium, is typically caused by a trigger, something that caused it, like an illness, such as an infection, a change in medication, or a new medication. And dementia, as of now, there's no curative treatment. There is a drug that has been in the news for some time, aducanumab, and that's maybe one of the first medication that could offer some potential cure, but as of now, we don't have any curative treatment that is offered. In delirium, when you reverse the cause, when you treat that infection, or the patient had, myocardial infarction, and that's treated, so it gets reversed. And in dementia, we treat with a symptomatic treatment that we're going to talk about. And there are some lifestyle changes that can help slow the progression. And delirium and dementia have this relationship to each other. So people that have dementia are prone to have delirium. So, but then at the same time, somebody that doesn't have a diagnosis of dementia and then they develop delirium, they're actually at higher risk of developing dementia, which actually could mean that they had some sort of cognitive impairment, and something that changed in their health just put them on the other side of developing delirium. Now, what is the process when somebody has cognitive changes? So it starts by history taking. We talk to the patient. We try to understand what are the symptoms that they're experiencing. It is common in cognitive impairment that sometimes there's no awareness of symptoms. So we typically try to find somebody, a confidant that knows the person well. Could be a family, a family like a spouse, children, or a friend, right? Anybody that knows the patient well, and they can tell us, oh yeah, I've seen a different difference in cognition in the last, I don't know, like 2 years, 3 years, right? And then we do an exam. We try to first look for if there's anything neurological, right? Like in signs like somebody had a stroke, or they have signs of Parkinsonism. And we do a screening cognitive testing that I'll show you in a minute. If they're abnormal, if there's anything abnormal, we definitely do a workup. Sometimes we do a neuropsychological assessment, especially when there is when we need clarity to see if somebody really has cognitive impairment. Sometimes they're doing okay in the screening testing, but then they really notice a change, or somebody else notice a change. So we do this type of assessment, which is a couple of hours of cognitive testing that goes very deep into the cognitive domains that I had explained before. And then these results are compared to people their age and their level of education. And then we do some neuroimaging, typically an MRI. People that cannot have an MRI, then they have a CAT scan of the brain. Sometimes we do other more specialized types of imaging. If they're available, I'm not going to go into detail, but there are other type of imaging that measure the metabolism of certain parts of the brain, or they look for the protein of amyloid in the brain, and which is related to Alzheimer's disease. And then we do some blood work, routine blood work, to make sure that there is nothing else that may be contributing to some of the cognitive changes, which includes checking the thyroid, vitamin B12 level, if there's any screening for syphilis, because neurosyphilis can cause cognitive impairment, and that's something that can stay in the body for years and not cause any problems until many years later. And making sure that the medications that they take, they don't have any cognitive impact. Some of the most common ones that I will say right now is Benadryl, or like antihistamines that are like first generation. They are in older adults, they're really not recommended because they can cause confusion, especially anybody that already has cognitive changes. And then, well, obviously, like ruling out if there's a brain tumor, which is like really never the case, rarely the case. I don't think I've ever been surprised, like not expecting a tumor and then they found something, right? There's usually something in their neurological exam, but the MRI would show that. And then other type of testing, like I said, more specialized testing, or sometimes we need to do a lumbar puncture, where we look for the cerebrospinal fluid, the spinal fluid, to look for other abnormalities. For example, somebody that has less than a year of cognitive changes, and then there's concern for something autoimmune, we might do that. Here is an example of one of the most common cognitive screening. You may have already heard of it. This one, and then also the MMSE, which I'll show in the next slide, are probably the most common cognitive testing. They have most of them at 30 points total, and then as you can see, has different aspects of cognition, not just memory. Like there's a part where you learn a list of words, and then they ask you later what's the list. But there's also a visual spatial component here, copying a figure, drawing a clock, doing something that we call trails, which is more executive function, that you have to follow a pattern. And then some language component in naming, some attention testing, and then orientation questions. And then we have the mini mental state examination, also has 30 points. This one has is more geared for memory, because Even 10 points from this test is just orientation, and then there's no really executive function component here, but still a good test for screening. Here we have an example of an MRI that we see somebody in 2017 and then 2020, how there was a change in the structure of the brain, right? Particularly, we take a look here at the hippocampi. This is one hippocampus and the second one, and then the two hippocampi, they seem that they have shrunk. If you see, there's atrophy. And this is typically seen in patients that have Alzheimer's disease. This is the case of Alzheimer's disease. But again, an MRI doesn't make the diagnosis. It's something that you have to take into account by seeing the patient, having a proper examination. Now, there's a clinical progression of cognitive impairment, as I mentioned before. And we spent some time talking about mild cognitive impairment. Now we have also the stages of dementia, right? Because that can also be very different, something that is mild from severe. So mild dementia is really when they just met criteria for dementia, which means that they have lost the ability to do a daily function on their own. It can be just one, maybe just medication, or it can maybe I think I went back, or can be driving or cooking. And then we have moderate dementia, where we have now people that have difficulty doing basic activities of daily life. So basic activities are personal care, moving or transferring, eating, bathing, using the toilet. That's more moderate dementia. And then we have, and this can be like difficulty in one of them, or all, or some of them. But then when somebody becomes totally dependent for basic activities of daily living, then that's more severe dementia. And then typically we see more in moderate and severe dementia, much more difficulties with cognition, like difficulty with problem solving, very significant memory issues or repetitiveness. They don't recognize family members. They have difficulty understanding instructions. And very important here, we start to have more concerns about safety. Although the safety concerns, should be addressed, early on too, or preventing from something to happen. But we see more of that in moderate or late mild dementia or moderate dementia, and more behavioral disturbances. And severe dementia, this is, like I said, a situation where patients are much more dependent. They have difficulty moving independently, or they might have decreased speech or become pretty quiet, aside from the people that have primary progressive aphasia, or they start to have difficulty swallowing. And now this is a hopeful part of the presentation. So now the question is, can we prevent cognitive impairment? And actually the answer is yes. In up to 40% of cases dementia be prevented. So there was, there are studies that show that either 40% of dementia can be prevented or delayed. And that's a big percentage. These factors are things that can be modified throughout the life of an individual, and it's never too late. Now it starts from the beginning, which actually you see they quantify what's a percentage or how much each of these factors can contribute to this 40%, and we see that 7% it pertains to education. So we know that if people have lower educational attainment may have more risk of developing cognitive impairment. So that's one part. And then we also have other things that can be prevented. Hearing loss. So anybody that starts to have some hearing difficulties, they have to go to the audiologist and try to see if they can, use a hearing aid or if there's anything else that they can do to correct the hearing loss. Traumatic brain injury, hypertension, alcohol. Here it says 20 units per week. It basically means about 12 standard drinks per week. More than that, that is a risk factor for cognitive impairment. So if you drink 2 glasses of wine per day, every day of the week, that might be a bit too much. Now there's also obesity, smoking, depression, social isolation, physical inactivity. And here the recommendation is obviously start the earliest that you can do that. Definitely that's the answer, but anytime is good. And the recommendation is for 150 minutes per week of moderate intensity exercise, meaning that when you exercise, either you break a sweat or you feel like your heart race a little bit, or you couldn't keep like a conversation if you were doing that exercise. That sort of an indication that it's moderate intensity. Although any exercise is good, even if it's just a stroll, down the street, still good. But I'm just saying, what's the recommendation? We also see that air pollution, diabetes, these are all modifiable risk factors for cognitive impairment. So what is the treatment when somebody is diagnosed with a cognitive impairment? So, it depends in the staging. Typically for mild cognitive impairment, we try to discuss some of the lifestyle changes, so such as exercise, having also a diet like a Mediterranean diet is also helpful. There are no supplements that can that have shown to improve cognition. I just wanted to say that because I think somebody asked this question. There have many studies, but none of them have shown a benefit, or at least like reputable studies. And also we recommend increasing engagement, like socially, cognitively, and again physically. Now, when somebody has dementia, and if we find that it's either Alzheimer's disease or Lewy body, we typically start a medication called Aricept that you may be familiar with, or donepezil. And this medication it doesn't modify the disease. It gives sort of like a cognitive boost, I would call it, because in this type of diseases, there is a neurotransmitter that goes down, a substance in the brain that goes down, and then this medication increases that. And then we have other medications that are more moderate to severe dementia, which is called Namenda or memantine. Kind of works different from Aricept. It has modest effects. Sometimes we start medications like antidepressants or anxiolytics, because that can be common in cognitive impairment. And I put a question mark in aducanumab because we, it is approved by the FDA. You probably heard that there was an expedited approval, and at this point, it's still not widely available because Medicare is still in the process of figuring out how they're gonna if they're gonna pay for it. I think they already said that they would like for another study to happen, but they haven't given the details. Now, this medication has shown to reduce the plaques of amyloid in the brain. And there seems to be a signal in one of the 2 studies that may decrease the progression of early, like mild cognitive impairment or mild dementia of Alzheimer's. Now, it is controversial because there were 2 studies. One of them showed that signal, the other one did not, or at least it was not statistically significant. And then there's also controversy about the potential risks of something called ARIA, which is the amyloid-related imaging abnormalities, which is possible swelling of the brain or bleeding. But typically in those participants that had aducanumab, in developed area, they were not, they were not severe, and are actually asymptomatic, most of them. But anyway, like that's something that we may start to hear more, or actually there's other studies of similar medications that are on trials, and who knows, like I think in the next few years we'll start to see more of them. Which definitely there are many clinical trials looking into this. So I am very hopeful about the possibility of treatment or modifiable treatment in the future. And a vital part of the treatment are some caregiving strategies that Howard will talk more about that, because it can be really hard, right, to take care of somebody that may have cognitive impairment, or they may not be aware of their cognitive impairment, or they have behavioral changes. And there's a way that we can help them also go through this process, and also for the caregivers to make it easier on themselves. And the other aspect of it, why it's so important to diagnose, because we can advise people, right, in terms of planning, and advise what may come in years, right? It's not something that will change, tomorrow, but in years, especially if it's early diagnosis. And there are studies that show that when somebody has an early diagnosis, they can participate more meaningfully in their care. For example, their advanced care planning. Because maybe in the future, in years from the early or from the beginning of the disease, they may not be able to participate as they would. Now, pretty sure this is the next part for Howard that I'm gonna pass it along, and I think I'm gonna be moving the slide for you, Howard, and let me know when you want to go to the next one.
You got it. And I think Twin can switch the presenter.
Yep, on it right now.
Hey, everybody. Thank you, Dr. Sanchez. That was really thorough. My name is Howard Hahn. I'm a clinical social worker. I got my master's in social work from Berkeley with a concentration in gerontology. One of the great things about our clinic is that we have excellent neurologists like Dr. Sanchez, but also a team of behavioral experts and social workers and therapists to help with behavioral management, because it's very challenging for caregivers and loved ones of people who have dementia, because there are a lot of personality changes, a lot of behavioral issues, and I'm going to go into that a little bit about sort of the best practices of what to do. A lot of people in, the common conception is that it's all memory. If you're losing your memory, you have Alzheimer's disease or dementia. And Dr. Sanchez mentioned that it's not. There are other things involved as well. Obviously, the brain is responsible for many functions, and those are behavior, mood as well. Some of the behavioral disturbances that can happen in dementia are apathy. People are just, go-getters who used to do everything, just all of a sudden are like, nah, I just want to sit in the chair. I'm really not interested in anything. Depression and anxiety. There's irritability. Sundowning, which we'll get to in the next slide, which is behaviors that occur later in the afternoon. People have delusions and hallucinations in certain type of dementias. The difference is delusions are thoughts, and hallucinations are actually where you see or hear something. A delusion, a common delusion with people who have Alzheimer's disease and other dementias are if they want to hide their jewelry, and then they've hidden their jewelry, and the memory issues on top of that, they can't find their jewelry, the delusion is that the caretaker or the house cleaner or somebody stole that jewelry. That's a very common delusion. Hallucinations, sometimes they see people who aren't there, hear things that aren't there. And then a big behavioral issue that a lot of people struggle with is resistance to care, showering, taking medications, just not wanting to participate in those things. And the next slide. We mentioned sundowning. Sundowning are a lot of those mood and behavioral changes that often occur in the late afternoon or evening in people with Alzheimer's disease or similar conditions. We think it's possibly because of the circadian rhythms, or we don't know why it has to do necessarily with the end of the day. But these behaviors that I mentioned earlier can sometimes be worse towards the end of the day, and that syndrome would be called sundowning. It's a very common cause of caregiver stress, and it's very difficult to manage those behaviors. There is a phenomenon called sun-upping, where these kind of things happen in the beginning of the day, but it's much more rare than sundowning. Sundowning happens in perhaps 20 to 30% of people who have dementia. Next slide. Some of the communication strategies to mitigate these behaviors, these mood changes, making eye contact, speaking clearly, allowing the individual plenty of time to answer, so that's just not plowing through. For example, there's a condition called primary progressive aphasia and some variant of Alzheimer's diseases where speech is a problem, and some people want help with word finding, some people don't want help with word finding. So in couples therapy, one of the first things I do with these people is say to the patient, do you want your husband or your wife to fill in the word or not? Because it's very common that people will say, no, no, give me a minute, I'll get it. And other people are more comfortable with saying, oh, just tell me the word, it's just easier. And that can cause some friction if the two members of the couple are at different ages. So it's important to have that discussion. Understanding that the person may be frustrated by communication challenges. Give the person a sense of success and avoid pointing out deficits. There's no point in saying, oh, I told you so, or why did you do that? Because we always have to remember that this is a disease and the resulting behaviors are not the person's fault. It's because they're going through something. For people who aren't close or who visit occasionally, the person may not remember meeting you. It's always a good idea to introduce yourself. In the same vein, it's always good to, if they're in sort of the mid stages of dementia, to sort of carry the conversation, not necessarily, hey, what did you do today, but talk more about your day, more about your memories with the person, so they don't have to think as much and fill in the blanks. And I'm going to mention this about 50 times. Never argue. You will never be right in arguing with somebody who has dementia. They are living in a certain reality, and logic is not your friend. So the people who have the most difficulties, I find, who have partners or parents, grandparents with dementia, are engineers, are people who are really logical, who need to be right. It's a bad recipe, because you really have to be more flexible and sort of go with the flow and go into their reality a lot of times. Next slide. Some memory aids, putting up a big calendar with the days of a week and appointments, so the person feels like they have some agency and they don't have to constantly ask what's happening when. This, of course, with the understanding that they can still, know the day of the week and follow a calendar. written reminders, large labels. For example, if a person is kind of in mid-stage dementia, you could write underwear drawer on the drawer, or do not use on the oven burner, things like that, which include safety instructions, lists, directions to find necessary items. In later stages of dementia, sometimes actually people have difficulty finding where the bathroom is, or from the bedroom, where they'll open a closet, even though they've been in that house for years. Some things that we've done that has worked is doing some lights at night, directing from the bedroom to the bathroom, and so that gives the person a little bit of a guidance of where they need to go. And then using a whiteboard, if a person has difficulty talking but they can still write, it gives them, again, a sense of agency, that they can still communicate. Next slide. This is instead, it's really best practices of things to do and not to do. Again, you never want to argue with the person, and it's instead agree. You don't necessarily have to agree, but you don't want to argue. You can say, oh, I can see you're frustrated, or and then divert them. Do not reason, divert. Do you want a cup of tea instead? Don't shame them, reassure them. Do you remember is not really a good thing to ask. We know a lot of people who like to test people who have dementia. Hey, what's our address, or what's our phone number? That really, I found, is more for the person who's asking the question rather than the person who, because you're testing them, and this is a progressive disease. So it kind of is your testing of where they are. Doesn't help, because it just highlights the fact that if they don't get the answer right, so you really don't want to ask, do you remember? You really want to fill in the blanks for them. It's not making them think more, or it's not helping them by asking them those questions. Don't never say, I told you so. Oh, you should have listened to me. Again, this is nothing that they control. Don't say you can't. Well, how about we can't, this is not good right now, but let's do this instead. Again, diversion. It's never a good idea to command or force. You want to ask. Modeling is really important. Hey, let's do this, and do it yourself. Don't condescend. You want to be as authentic as you can. And for the caregiver, it's very important not to isolate. And it can be a very lonely place to take care of somebody. So you want to find support, a community that you can share these things with. And the Alzheimer's Association is a great place to start. Next slide. Some more communication strategies. Focus on the person's abilities instead of their deficits. So adapt strategies to each person's changing cognitive levels and needs. For example, if the person used to cook, but they're kind of dangerous now in the kitchen, you want to be able to have them participate. Hey, honey, could you chop up these carrots? Could you peel the potatoes? Would you do me a big favor and fold these towels after doing the laundry? Whether they do it right or not is not really the point, and the point is to have them participate and have them feel like, again, that they're contributing. Becoming a creative listener, focusing on verbal and nonverbal communications. We'll talk a little bit later how important nonverbal communications are, because sometimes people lose their words as dementia progresses. And be aware that behaviors and expressions of emotions are common methods of communication. So there can be some outbursts, there can be some emotions, but it's underlying something. So it's better to listen to the underlying expression of the emotion rather than the words themselves sometimes. And again, we'll see that in a second as well. Okay, yeah, and people who have dementia may not be able to speak coherently. They're still able to understand you and connect emotionally. Next slide. So helping the person communicate again, this is like the third time, avoid arguing. It may lead to yelling, crying, striking out. Look for emotional meanings and subtext behind statements. For example, someone who's waiting for her mother, you don't want to bring them back to reality and say, your mother died 20 years ago. There's no point to it. You're only introducing the trauma again. What you want to do is listen to the emotion behind that is, I'm lonely, I'm scared, I need support. So what you can do is say something like, wow, you and your mom must have had some good times together. Tell me about them. What did you used to do with your mom? So making them feel more secure. You know, putting their reality, pulling them back into your reality is not really a good thing. You want to go into their reality and make their emotions, listen to their emotions and make them calm and feel supported. Again, mirroring is a really good thing as well. If you're frustrated, they're going to see that on your face and feel that there's something to be frustrated about. If you're angry, they're going to be angry. If you're sad, they're going to be sad, because why? It's mirroring. My husband said, my wife said, my child said, there must be something I need to be sad about, because the emotions, again, are much more to the surface. So you need to be as calm, collected, cool, happy as possible. And again, get support somewhere else, because this is not easy. But getting frustrated with the person, showing your frustrations, sadness is not a good idea, because they will just mirror that. Next slide. Yeah, again, therapeutic storytelling, where the person's reality is different from yours. The goal is to simplify reality so the person's easier to manage, the situation is easier to manage. Examples are, a patient thinks you're their mother. We went into that a bit. And it's okay. I don't convince them you're not. There's no reason to convince them you're not. It's painful and it's hurtful and it's scary, but that's something that you as their caregiver have to deal with, but do not sort of put them on them. They have their own reality, and it's okay. One of the questions, I think, was like their mother is back in their kind of childhood and is kind of singing the same song. It's okay. We'll show a little later on, putting on songs from when they were younger is perfectly fine, and that's okay. You just go with it. Okay, next slide. More communication strategies to help the person understand you. Use words that are familiar. When possible, as dementia progresses, if you can, speak in their native language, because a lot of times their language goes back to their native language and they lose a little of their newer language. Avoid open-ended questions. Offer yes or no questions or a choice. So this can be practiced, for example, if you take the person out to dinner, out to a restaurant. I wouldn't necessarily hand them the menu, depending on what stage of dementia they're in, because it can be overwhelming and it can be stressful. What you can say is, you know what, Mom, you love the tuna and the burger here. I'm getting which one do you want? Or you can say, you know what, Mom, I'm getting a burger. Do you want one of those too? Most of the time, the person will say sure, and it's a relief to them not to have to navigate all that. So open-ended questions are not great. Again, leading the conversation, offering choices of yes or no, or two things or three things. Repeat or rephrase when the person doesn't understand. Break down tasks into clear and simple tasks. A good example of that is not to say, honey, can you set the dinner table? Because that's super complex. What you might want to do is say, honey, from that top cabinet over there, can you get the large dinner plates and put them on each space? Now, can you open that cabinet and get the salad plates and put them on top? So it takes a lot more time, but again, they feel like they're contributing, and you're giving them tests up to their ability and not past their ability. And then, of course, a smile, hug, or other expression of affection really means a lot as well. Okay, next slide. This is what we were talking about before in terms of nonverbal communication. Make sure the person is comfortable. A lot of times, if you see a wincing or some sort of pain, sometimes they're not able to communicate exactly what's wrong or where it's wrong. So make sure all of these things are checked. Hearing aids, eyewear, dentures. Do they have a toothache? Is it hard when they eat? Are they hungry, thirsty? Is incontinence involved? And then pain and discomfort. Generally, you'll want to kind of delve into a little further, because like I said, a lot of times they can't pinpoint what the issue is. Next slide. So a little bit about caregivers themselves and the disease. In 2018, more than 16 million caregivers provided an estimated 18.5 billion hours of unpaid care. Anybody who takes care of a loved one with dementia knows how difficult it is. The economic values came up to about $234 billion of unpaid care. And more than 60% of Alzheimer's and dementia caregivers rate the emotional stress of caregiving as high or very high. And 1/3 report symptoms of depression. So it's, again, really important to take care of yourself in order for you to take care of the person. It's almost like, putting the oxygen mask on you before you put the oxygen mask on the person next to you. You need to be able to still go out and still enjoy yourself and still have a semblance of a life, so you can take a deep breath, a couple hours here and there, to come back and do it again, because you can't do this 24/7. And so that's why it's really important to consider getting either caregivers in the home or taking them to a day program, because we really need to replenish your sense of self. Next slide. A good practice, we have a course called Mindful-Based Dementia Care at the clinic. And it's stop, take a breath, observe, and proceed. A lot of times, people who take care of folks with dementia are very reactive. Put that down. I told you that 100 times. We discussed that yesterday. When you sense yourself tensing up, it's important to stop, take a breath, observe your surroundings, kind of realize, okay, the person is not doing this on purpose. They have a disease, and then proceed without being reactive. There was one question in the chat that said, how do you get the person to stop asking questions, or how do you deal with it? So it's very frustrating for somebody here. Where are we going? 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 And it's normal to get frustrated. What you have to realize is understand that the person probably will ask you that same question 10 minutes later. Have a script for yourself. Oh, we're going to the neurologist at 2 o'clock to get a brain check. Or we're going to the heart doctor at 3, and just have a script for yourself. Every time they ask, you say the same thing, and expect them to. And then that tension in yourself will go down. The tension arises because you expect them to do something different, or you're hearing that question again. They're not repeating the question and saying, boy, this time, watch her blow her stack. It's because they have a disease, and treat every time they ask as the first time they're asking, because it in reality is the first time they're asking. Next slide. Problem with dementia, problems, many are impacted. It's very under-recognized because some of the first signs are emotional or behavioral. It does go undetected a lot. The healthcare system is really unprepared for the amount of people that there are that are coming in and will come down with it. Physicians are unsure about how to diagnose and treat them. In the general population, it's a really difficult conversation to have of a patient you've had for 20 years to say, hey, I think there's something going on with you. And a lot of people don't have the skills to have that conversation. There's a lack of awareness and information, and families, delay seeing help because this is not something that anybody wants to admit. So, well, it's just aging, and it's really important at the first signs where your gut says, I think something's wrong, to have the person checked out, because as Dr. Sanchez mentioned, early treatment means that you can have possibly a longer period of clarity of time with medications and treatment than you would at a later point. And it's all about quality of life. And of course, it's extremely expensive. Next slide. Changing the culture of care. Again, this is kind of just talking about how much of a stigma Alzheimer's disease is. It really is one of the last diseases that has the stigma. Cancer used to have a stigma, and that changed, I think, in the 80s, where people used to whisper, "Oh, he has cancer." That has changed, and I'm hoping Alzheimer's does as well. It's a disease like any other disease. It's a disease of the brain, and it's scary, but it's nobody's fault. Changing our attitudes, acknowledging fear, bias, and stigma and discrimination. People with dementia remain unique individuals. They should remain the driving force in their lives and care whenever they can participate in it. And well-being is not totally dependent on cognitive or functional ability. You can have wonderful connecting moments with people who have dementia on an emotional level. Coordination of care, which we do at the Brain Health Center. It's good to have social workers involved. It's good to have the primary care physician involved, specific neurologists, strategies of care, and follow through. And identifying unmet needs and using creativity to fill them. Great things to do with people who have dementia are art, song, dance, music from when they were a child. If they can still write, it's great. Going through old photo albums, because a lot of times it's their short-term memory that's affected most, but their long-term memory is still largely intact. And they can remember a lot about, every detail they had at their wedding day and who didn't show up. And so it's nice to go through photo albums. It makes them feel normal. It makes them feel like they're remembering and they're part of the world. Next slide. So some final thoughts, and most, all people are unique, deserve to be treated as individuals. Dementia affects everyone differently, so that's really hard too, because there's not a template. Some people have behavioral issues. Some people are wonderful and passive and accept all the help. Some days will be better than others. It's called complicated grief because your husband or wife can be great on Tuesday, not be good on Thursday, and then can be fine on Friday again. So it's hard on the caregivers. And remember, the goal is to connect. I have a little video here which I want to show you. It's part of a documentary called Alive Inside, created by a social worker who realized how much music meant to people who have dementia, and how much it can connect and bring the person out. I'll show you a little clip to show you what the person slumping in the chair can actually be engaged and be really brought to life.
Hi, Papa. Hi, Papa.
Huh?
How you doing?
I'm all right. I'm fine. Wait.
Who am I?
Wait a minute.
Okay, it's Cherry.
How long has he been in the nursing home? Approximately 10 years. He was having seizures, and my mother couldn't handle him at home. Of course, it affected me greatly because he was always, fun-loving, singing, every occasion he would come out with a song, no matter where he was. I remember as a child, he used to walk us down the street, me and my brother, and he would stop and do Singing in the Rain. He would have us jumping and swinging around poles. He was, he was good. He was always into music, always loved singing, dancing.
His name is Henry Dreyer.
Uh-huh.
And I'm looking more or less for religious music for him.
Okay.
Because he enjoys music and he always quoting the Bible. So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah.
Henry.
Yes, sir.
I found your music. You want your music now?
What do you want me?
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression. His eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
The philosopher Kant once called music the quickening art, and Henry is being quickened. He's being brought to life.
Yeah.
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay? I'm going to give it back to you.
Uh-huh.
Okay.
The effect of this doesn't stop, because when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry,
Yeah.
do you like the iPod? Do you like the music you're hearing?
Yes.
Tell me about your music.
Well, I don't have one, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound. Beautiful.
Did you play music when you were? Did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, Cab Calloway was my number one band guy I liked.
What's your favorite Cab Calloway song?
Oh, I'll be home there for Christmas. Oh, you can count and plan on me with plenty of snow, mistletoe, present wrapped around your tree. Ow!
So in some sense, Henry is restored to himself. He has remembered who he is, and he's reacquired his identity for a while through the power of music.
What does music do to you?
Give me the feeling of love, romance. Figure right now the world needs to come into music, singing. You got beautiful music here. Beautiful, oh, lovely. And I feel the band of love, the dream. The Lord came to me, made me holy. I'm a holy man. So he gave me these sounds. I'll just say, I meet you. Let me see. Rosalie, won't you love me? Rosalie, won't you be sweet and kind?
With this beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate, organize, and bring a sense of identity back to people who are out of it. Otherwise, music will bring them back into it, into their own personhood, their own memories, their own autobiographies.
So I just wanted to show that clip to see that it doesn't take a lot to bring a person out of themselves. If they're slumped over, they just need, sometimes the more you know about the person, the better it is, because you'll know how to engage them. And it just kind of demonstrates that. Thank you, guys. I think we're going to take some questions with some time remaining. Yeah.
Yes, I think we have less than 5 minutes for questions, and I think we'll have to do a little bit of a lightning round. But I do know that you might have already touched on. The first question we have here comes from our registration. Is there data to show if aromatase inhibitors post-hormone positive breast cancer increase one's risk of Alzheimer's? My mother died of Alzheimer.
Well, I think, like when people get this medication, obviously that there's a need for these, right? And, it is controversy about the role of estrogen and testosterone or lack of it in terms of neurodegeneration, but then not that there's any data to say, we shouldn't give this medication because it will cause Alzheimer's disease for sure, right? So I think, maybe a vague answer, but then nothing that, will say, oh, this was the cause of Alzheimer's. So yeah.
Thank you. Next question. This asker says, my 93-year-old mother lives now back in time. She also hears songs. I want to learn how to handle her condition. I think Howard, you touched on this a lot.
Yeah.
Yeah, it sounds like also she has maybe a little auditory hallucination, so you could be curious and ask her, what do you hear, and right?
Yeah. What's the tune, and hum along with her.
Yeah. Exactly.
Our next question is about supplements, and if you have any that are recommended.
So there are no supplements that can prevent or help cognitive impairment unless somebody has vitamin B12 deficiency and they need a supplement. But that would be the only exception. Okay.
Do people sense the onset of cognitive impairment before it shows up in tests?
Some people do. That's what we call subjective cognitive complaints, and they start to feel, there's something changed in my cognitive function. Some people don't, but then if they feel it, they should get checked.
What are warning signs? What can be done to prevent or mitigate? And what are available support/services?
Well, I think we touched on the warning signs and prevention. I think some of the support and services options are organizations like the Alzheimer's Association, Family Caregiver Alliance. Those are two big ones. I don't know if Howard, you.
I think those are two really big ones. The Alzheimer's Association has a 24/7 hotline. They can put people in touch with caregiver support groups, and they're great. Family Caregiver Alliance also is great.
Our next question is from Elaine. Are there any tests that one can request to take to test for Alzheimer's disease or dementia early on?
Well, we typically do testing in people that have some cognitive changes. I don't think anybody, if they don't have cognitive changes, we don't recommend certain tests. How I would answer like that. But tests for Alzheimer's, there's like imaging, screening, cognitive testing, neuropsychological assessment, and sometimes we do amyloid PET. Or Alzheimer's disease biomarkers in spinal fluid.
Great, thank you for your answer. And I think this next question would be helpful since you have the share screen already. Marilyn asks, according to your chart, a recommended medication is Aricept, which is a cholinesterase inhibitor. Does that mean that B vitamin choline may be helpful?
So, this medication acts in the brain, right, inhibiting the breakup of acetylcholine, so raising the acetylcholine in the brain. So, which is different from, taking a supplement that might be the same thing, but it doesn't correlate with the brain. So, there are unfortunately no supplements that are proven to improve cognition.
Thank you. And I know that might be just me, but I think the screen is blocking, like there's something blocking your email. I'm not sure if Howard sees what I see.
I do see what you see. I see the
Okay.
first half of our email, but there we
Got
go.
it.
Yeah, yeah.
The last question comes from an anonymous attendee, and it's a little bit of some background here. My mother thinks that my dad is here and wants to go get him. He passed 3 years ago. The situation goes on for half a day. She even many times starts to sob. How can you handle this?
This is extremely common, and the situation probably goes on for half a day because our instincts are to convince the person that their dad is dead. So what you should do is just say, oh, because of COVID, we can't travel right now, but we'll be happy to do that when we can. Or just placate the person. I wouldn't necessarily tell them that the person died because that revisits the trauma. And again, you're trying to go into their reality. So it's okay that their dad is alive. It's fine. It's just, you try to make the situation as good as possible and say, well, maybe we'll be able to go next month, or it's raining out, we can't go today. And because the person has memory issues, they don't necessarily, remember that you said that. So you can keep doing that, kind of placating, so it doesn't last half a day.
Thank you. That was our final question. And if anyone has a last minute one, you can feel free to type it now. I will start our closing. Oh, I see that Tony has raised his hand. So I will go ahead and allow you to talk, Tony. Please unmute yourself.
Thank you. I'm curious about the impairments as a result of chemotherapy, and if that increases the risk for future dementia, and if there's any hope for those impairments to go away.
So that's a great question. So there are some chemotherapy agents that can act in the neurons, or like the nerve system, right? And there are changes that can come with certain type of agents, they call the chemo brain, right? And they're different from Alzheimer's disease, and for these we would have to go over which type of agents were given. I have to do a neuropsychological assessment, but there are changes that can be related to chemotherapy, typically not progressive, like an Alzheimer's disease, which is a neurodegenerative disease. But yeah, there's a lot of research and again controversy about that, but there can be some changes.
But no specific research about people who have had multiple cognitive impairments after chemotherapy having greater risk of having later diagnosis of dementia or Alzheimer's?
Yeah, not Alzheimer's, but there is cognitive changes from certain ages of chemotherapy.
I know, I'm living through it. I'm well aware of that. And I also asked the question about aromatase inhibitors. So basically, has that just not been studied specifically? Is that why you gave such a vague answer?
No, we've studied like aromatase inhibitors, and also sort of like testosterone blockers as well in other patients, like in men. But there's a lot of, again, like controversy about like lack of these hormones. Like if you take these hormones away earlier than you should, there's some some aging process, right, that can cause some cognitive aging, but not that it causes Alzheimer's disease.
I just feel like I have a lot of strikes against me. My mother had Alzheimer's symptoms for 19 years before she died. I have very many symptoms that you described today in your program based on the chemotherapy that I took. And now I have to make the decision about whether or not I want to take aromatase inhibitors. And it's like, if the brain needs estrogen, I don't want to put another strike against me.
Yeah, it's a difficult decision, but I wouldn't, I don't think, in my opinion, that should, take precedence versus taking, an important treatment to prevent a disease from.
Yeah, that's what they told me when I took the chemotherapy, and now I'm so impaired, it's very hard for me to take care of myself. So I'm skeptical, but thank you so much.
Yeah, you're welcome.
Good luck.
Thank you so much for your discussion, Tony. I'd also like to thank our speakers from the Ray Dolby Brain Health Center. Thank you for making this very educational for patients, but also caregivers as well. I think that goes a long way.
Okay. Thank you for having us.
Yeah, thank you for having us.
If you have any other words for our participants before I close out today, please feel free.
Just echo Dr. Sanchez's statement before that early diagnosis is really important in this situation, because it really improves the quality of life you have left. And so you want to be detected earlier than later.
Thank you. Have a wonderful weekend, everyone, and enjoy your night.